Hello, everyone, and welcome to our webinar Wednesday held on a Thursday. Today's topic is going to be smoking cessation, and we have a panel of researchers who are going to be talking about their work today. As a reminder, for those of you who are joining us on Zoom, please make sure you're muted when not speaking to avoid any background noise. This webinar is streaming to Facebook Live and will be later uploaded to our YouTube channel. Please use the chat box on Zoom to ask questions during the presentation. And for those who are watching on Facebook Live, please use the comment section to ask any questions. The Webinar Wednesday series is part of the Healthy You virtual education and engagement initiative. And it is a program of the University of Chicago Comprehensive Cancer Center Office of Community Engagement and Cancer Health Equity. My name is Aaliyah Poulos. I work as an education outreach specialist in this office, and I'm joined by my colleague, Erica Rodriguez, who's also on the Zoom today. So if any questions come up, you can feel free to message either one of us. So today's webinar Wednesday is being held on a Thursday because the third Thursday of every month is the Great American Smokeout, which is an annual intervention by the American Cancer Society. It was first held in San Francisco's Union Square in 1977, and it evolved from smaller scale local anti-smoking initiatives. And the Great American Smokeout challenges people to quit smoking just for the day and then make a plan to quit permanently. Approximately 40 million Americans smoke, and tobacco remains the single largest preventable cause of disease and premature death in the United States, which is why the American Cancer Society does take a day out of the year to focus on anti-smoking initiatives and campaigns, and that is today for the Great American Smokeout. So we have three panelists today who are tobacco cessation researchers at the University of Chicago. We have Dr. Ashley Vena, Dr. Anna Veluz-Wilkins, and Dr. Emma Brett, who are going to be speaking about their work today. I'm going to stop sharing my screen and throw it to Dr. Vena, who's going to be our first speaker.
Thank you, Aaliyah. Let me go ahead and get my screen share set up. All right. Can everyone see this?
Yep, looks great.
Cool. So good afternoon, everyone. My name is Dr. Ashley Vena, and I am the Scientific Director of the Clinical Addictions Research Laboratory here at the University of Chicago. And this is led by Dr. Andrea King. And our lab is really interested in understanding the risk factors that might make it more likely for someone to develop a substance or alcohol use disorder. But we're also interested in identifying targeted treatments to help people dealing with these conditions. And so today I'll be presenting some research that is one of these treatment studies, the Chicago Stop Smoking Research Project. And this was a smoking cessation clinical trial for heavy drinking smokers that we actually just finished up later last year. So jumping right into it, we know that tobacco and alcohol use are two of the top three leading causes of preventable deaths. And many people co-use these substances. And this makes sense given what we know about the ways that nicotine and alcohol interact with the brain. They actually, when they're used together, can have an additive effect on activating our brain's reward pathways. However, people that do co-use these substances are more likely to experience health-related harms, that more so than using either substance alone. And this includes the risk of cardiovascular disease, lung disease, and various cancers. So tobacco use alone is associated with 1 out of 3 every cancer deaths. And so when you have a group of individuals that are smoking and then also drinking heavily on top of it, you're really amplifying those health-related harms. So I've been saying heavy drinking, and what does that mean? Everyone might have these preconceived notions of what heavy drinking entails, but we use the definition put forth by the National Institutes on Alcohol Abuse and Alcoholism. And they define heavy drinking a little bit differently depending on the biological sex of the individual. And this is really due to differences in metabolism between men and women and how alcohol is distributed throughout the body. So for women, heavy drinking would be 4 or more drinks on any given day, or 8 or more drinks per week. And then heavy drinking in men is 5 or more drinks on a given day, or 15 or more drinks in a week. And so using this definition of heavy drinking, keep in mind that these individuals do face some major disparities in quitting smoking. And this is what motivated us to do this clinical trial. So heavy drinking is associated with increased smoking urges, and it does make it a lot harder to resist those urges. So it's not surprising that heavy drinking smokers have lower quit rates than light or non-drinkers. And so this is even more so given the fact that there are no targeted treatments to help heavy drinking smokers quit smoking. Now, there are plenty of smoking cessation treatments available that are very effective in the general public, so nicotine replacement therapy or various medications. But we find that in people that drink heavily, these aren't quite as effective. There is one medication, though, Chantix or varenicline, that does hold promise. This was approved by the FDA for smoking cessation in 2006, and it is very effective in helping people quit smoking. But the early studies, they excluded people that drank heavily. So we don't really know much about it in people that drink heavily, although more recently we have learned that it is associated with reducing alcohol craving. And in laboratory studies, it does reduce the amount that people drink. And so this seemed like it might be a great fit. I mean, we're targeting both alcohol and tobacco use with the single medication. And so this does seem like it might be a promising route. And indeed, it is more effective for helping heavy drinkers quit smoking than using either nicotine replacement or bupropion alone. But we still see that quit rates in heavy drinking smokers lag behind those of non-heavy drinkers. And so we thought, well, you know what, maybe this population that's facing these really unique barriers to quitting smoking, maybe they would benefit from a combination treatment. And so that was our research question. Would a combination treatment approach be more effective for smoking cessation in people who drink heavily? And the combination we had in mind was varenicline and nicotine patch, which is a form of nicotine replacement therapy. And this was based on the fact that studies coming out at the time did show that this combination was very effective in helping people quit smoking, but these studies did not enroll people who drank heavily. So that was our goal and why we launched the Chicago Stop Smoking Research Project. This was actually one of our CTA ads. You might have seen it around Chicago. And for this study, we were recruiting people who were interested in quitting smoking, but they didn't necessarily have to change their drinking behavior. And we ended up enrolling 122 heavy drinking smokers, and they were assigned randomly to one of two conditions. So we had our active treatment condition, which was varenicline with nicotine patch. And then our control condition, they received a placebo medication that looked identical to varenicline, and then they also used the nicotine patch. So everyone in the study got the patch. It was, the only difference was the medication that they were taking. And this was a double-blinded study, meaning that as participants, they didn't know what medication they were taking throughout the study, and we as study staff didn't know either. And a little bit about our sample. So overall, the average age was about 44 years. We did have a big range, anywhere from our youngest person was 19 and our oldest was 82. And the sex breakdown was pretty similar between our two treatment groups, but also kind of along those lines of a 50-50 breakdown. We had a very diverse sample, as over half of our sample identified as non-white. And you can look at their smoking patterns here. So the majority of people, or on average, people had been smoking for about 25 years. So that's a little bit more than half of their lifespan. And these were mostly daily smokers, smoking about a little over half a pack of cigarettes per day. And then you can see their alcohol consumption, almost 25 drinks per week. So I'll break down this slide very quickly, but it's a little bit busy. But this is just an overview of what participation looked like. So the very first thing we did when people completed their medical screening at the very beginning, we helped them set a smoking quit day, and something that would fit with their schedule. And then we planned 4 study visits around that quit day. So the first study visit occurred 1 week before their quit date. And this is when they started the study medication, which they took daily for 12 weeks. They actually took that first dose of the medication in their visit. And then they also got their first round of behavioral coaching. So I haven't mentioned that yet, but we know that when you combine behavioral support with a medication, that tends to be more effective, especially when it comes to substance and alcohol use disorders. So we did provide some brief behavioral coaching, And this was a modified version of a program that's offered here at the University of Chicago called Courage to Quit. So we helped them plan for quit day, help them identify smoking related triggers, find ways to deal with any cravings or withdrawal symptoms. And so that was at visit 1. Visit 2 was on their smoking quit day. They came in, they had also started the nicotine patch that day, and they got a booster session of behavioral coaching. And then the 3rd and 4th visits were spread out throughout the remainder of their participation. And our goal here with this study design was to have something that would have real world practicality. It could be readily implemented with very few barriers. And our primary outcome was at the end of treatment, we wanted to evaluate people's smoking status. And so the 4th visit occurred with or coincided with the end of treatment. So participants would come in and they would let us know by self-report if they had quit smoking. And then we would verify their self-report by measuring breath carbon monoxide. And carbon monoxide, just to clarify, is a poisonous gas that you inhale when you are smoking. And so we have a monitor that we use that can quantify levels in people's lungs. And that's a pretty reliable indicator of whether someone's still smoking or not. So here's the data from our primary outcome. So the quit rates at the end of treatment, I have shown here in the black bar. Let me see here. Yes, in the black bar, we have the active treatment group, the combination therapy of varenicline and nicotine patch. And then in the white, we have the control group. And shown here are the percent of subjects that were abstinent during the final month of treatment. And we had a greater percentage abstinent from smoking. So this was a very strict cutoff. You couldn't even have a puff of a cigarette during these last 4 weeks. More people were abstinent in the combined treatment group than the control group. Now, I did mention that alcohol wasn't really a focus of this study. There was no expectation or requirement for people to change their drinking patterns, but it is something that we looked at. And so on the graph over here, we have their percent drinking days. So this would be the percentage of days during the week on which they drink alcohol. And at the start of the study, the 2 groups were similar. We see that roughly 65–70% of days they drank alcohol. And then what happened during participation? Well, we saw a steep decline in alcohol use or percentage of weekly drinking days early on in the study that kind of stabilized throughout participation. And there was no difference between the 2 groups here. For heavy drinking days, so this is going back to that definition I introduced at the start of the talk, the percent of heavy drinking days per week was similar between the 2 groups at baseline, so roughly 30%. And then we saw a similar pattern here with a major drop off early on in participation, but no differences between the 2 groups. So overall, what we learned was that this combination treatment really improved quit rates in this sample that can be have a harder time quitting smoking. We also saw major reductions in alcohol use in the whole sample, and this was very unexpected because, like I said, it was not a focal point of this study. But also equally important, these treatments were safe and well tolerated in heavy drinkers. So we did look at things like side effects, and they were very similar between the 2 groups. Things like nausea and headache were probably the most common. And so it's interesting, as researchers and scientists, we're always interested in looking at the data and the numbers and using that to help inform clinical practice. But the fulfillment that comes from running this clinical trial are those individual success stories. And we got a really lovely note from one of our participants at the end of her participation. And she said, "I've always said if I can get 1 week under my belt, I'm off and running. Well, after 42 years of smoking, I'm winning the race thanks to the C-Stop program. I have not had a cigarette since July 21st, 2018. And so this was at her 4th visit. So this was 3 months of participation. She had been smoke-free the whole time. And by 6 months, she was also still smoke-free. So with that, I would like to acknowledge Dr. Andrea King, who leads the Clinical Addictions Research Lab, as well as current and former staff members. Of course, acknowledge our funding. And then if anyone has any questions about any of this, feel free to shoot me an email.
That was great. Thank you so much, Dr. Vena. So we will have some Q&A for all of our panelists at the end, but if something comes up during the middle of a presentation, feel free to use the Zoom chat feature to ask that, or if you are on Facebook Live, the comments section will work for that. Okay, thank you so much again, Dr. Vena. Now we're going to hear from Dr. Veluz-Wilkins, and you can go ahead and share your screen.
Okay, hello, everyone. Let me just get this going. Okay, can everybody see?
Yep, looks good.
Okay. Okay. All right. Well, hello, everyone. Thank you for having me here today. My name is Veluz-Wilkins, and I am with Dr. Marcia Tan's Community Health Allies Training Research Lab in the Department of Behavioral Sciences. We work a lot around a variety of health behaviors, specifically to reduce disparities. So what I will be talking about today is our work in developing a tobacco cessation curriculum for community health outreach workers. I just want to acknowledge the lab here. Dr. Tan is not able to be here today, but I did see a few of our other lab members. I think I saw Clarissa here, and then Enrique, Leanne, and Dario are also members of the lab. So I know many of us already know that tobacco is again one of the most preventable causes of illness and chronic illness and disease in the United States. One good thing is that overall tobacco use rates are declining in the US. However, that is not the case for everyone. So again, although cigarette smoking is decreasing, there are still about 34 million American adults who smoke. And the problem with this is it really is very specific vulnerable groups that are still smoking, as you see here, men, adults, 25 to 64, but then as you see, lower income, lower education, low socioeconomic status, those below the poverty level. Also happens here in the Midwest. We have the highest smoking rate still, uninsured and those on Medicaid, those who are disabled, those who have serious psychological distress, Native Americans and multiracial populations, and the LGBTQIA population. And so these groups do carry the largest tobacco-related disease burden in the country as well. This graphic over here is from the CDC, and it is also recommended by the US Preventive Task Force that the most effective ways to reduce overall smoking rates are really these four things here at the bottom, but what we are focusing in the lab is the last one, which is making quitting help easily accessible to more of these vulnerable groups. The key problem really, especially with these high-risk populations, are that there's not as much exposure to information on tobacco cessation. Many patients with low income, actually up to 40%, do not see a primary care provider annually. And persons with low socioeconomic status are less likely to receive assistance with quitting during clinic visits if they do happen to go see their primary care docs. That rate's only really about 21%. And so again, I've mentioned this before. So one key way that we want to address this is by making access to evidence-based cessation more available. So how might we address this from an equity lens? Well, community health workers are frontline public health workers, and they are members, or they're trusted members of their communities, and they have close ties to the communities they serve. They serve as a link between the health and social services and the community members, and they do this to facilitate access to health services, specifically to improve the quality and the cultural competency of the health services that are delivered. So the Illinois Community Health Worker Advisory Board report that was published in 2016 did describe community health workers as the social determinants of health agents, because they really are on the front lines and they serve these vulnerable populations. So community health workers really can play an increasing role in tobacco cessation programs because they're well positioned to engage with persons with low income and all these other vulnerable populations outside of a primary care setting. They often go into homes, into patient homes. So for people who can't get on 3 buses to get to their doctor can still access these health services. Let's see. So our project is the Tobacco Cessation Curriculum for Community Health Outreach Workers. We are fortunate to have funding, some seed funding from the American Cancer Society and the V Foundation. Our study objective was to assess the educational need, the feasibility, and the receptivity of a tobacco cessation curriculum specifically tailored for community health workers, given their unique model of healthcare delivery. Our rationale was really that modifying existing evidence-based tobacco cessation curriculum, because we know that there's a lot out there that is very evidence-based and works, but tailored specifically for community health workers can reduce barriers into receiving trainings and therefore better equip community health workers with tools to deliver cessation interventions directly to their patients in these marginalized communities. So I'm going to be presenting just some preliminary results. We've really taken a mixed methods approach throughout. So we have conducted quantitative surveys as well as qualitative focus groups and one-on-one interviews with community health outreach workers. So for the needs assessment survey, we administered the survey to 58 community health workers and lung health professionals in Cook County, and we collected data on their client populations, the tobacco cessation services they're able to either provide or refer to, their general knowledge about tobacco use in the US and evidence-based interventions, and then the training needs of these health workers. We did this when both Dr. Tan and I were still at Northwestern Medicine, and we did it in collaboration with the American Lung Association. So in the due to time, I'm not going to present everything, but really for this talk and this presentation, the key results from our survey were really around tobacco services and practices. So many reported that, and these are community health workers and lung health professionals, many reported that they do in fact discuss tobacco use during their visits in accordance with the 5 A's, which again is the US clinical practice guideline recommended approach to addressing tobacco cessation. So 62% did in fact ask whether their patients smoke. But as you see, as you go through advising to quit, assessing willingness to quit, assisting in creating a quitting plan and arranging follow-up, participation in those activities decreases. So you also reported being extremely confident in addressing tobacco use at all in our sample. And I'm going to move on now to our qualitative focus groups. We actually had a few rounds of this. I'm going to present the qualitative focus group results from the 6 community health workers from a West Side community-based organization. So we had a semi-structured interview with these 6 participants, and we discussed the nature of their interactions with their patients, the specific patient populations that they serve, again, the tobacco cessation practices that they engage in, and what they really desire for trainings, and then the recommendations for how we can work with them for their training needs and developing this curriculum. There's just a few example questions. Can you tell me about your interactions with your clients and patients? Can you describe how you might address tobacco use dependence with your clients? And then what kind of training do you think would help you prepare to deliver tobacco cessation services? So we have quite a bit of themes that came up. One thing that I really enjoy is engaging with CHWs and hearing them talk about the work that they do with their patients, because they really are on the ground doing all the really important work. Relationships are everything. And so I'm going to present some of the key themes that we are really relying on as we move forward in our curriculum development. But the things that I'm going to focus on today are really the patient-client population that from the CHW perspective and the relationships that CHWs have with them. They really talk about their patient population and their client population. Again, we know this from basic epi-stats, but they do really serve the most vulnerable. They often have, they very frequently serve homeless populations, lower income populations, low health literacy populations, and CHWs are very integral in really bridging the gap in understanding what the health care needs are for their patients. And CHWs describe their relationships with their patients and their clients as almost certainly as a health educator role, but also much more like a sister or confidant role. And there's a lot more trust that they can develop over time, because, which brings me to the next thing, which is really the CHW model of care. There is a lot of flexibility in how they can deliver care to their clients and patients. There's great variability in the visit setting. So as I've mentioned before, they often will go into the homes of their patients, or really anywhere that their patients are comfortable. So that could be a restaurant, that could be a church location, that can be anywhere that there's some level of comfort, and where the CHWs can meet the patients where they are and really get them greater access to the healthcare. There's also often a more frequent and increased continuity of care. Many of the patients are referred to the community health workers primarily through a specific chronic illness, for example, asthma or COPD. But because of the type of delivery model that CHWs engage in, they can often see their patients and clients weekly to start, and then go to monthly, which is much more frequent than, for example, your primary care provider. CHW's current approach to addressing cessation was also discussed, which I will give you examples on the next slide, but there is really quite a range of approaches that you're currently using. And then lastly, I'll describe the training needs that they really were asking for. These are the current approaches addressing cessation. One participant said, I've had sessions encouraged to quit, and people will come and complete educations, but then they still smoking. So there was a discussion about their patients and community members going to establish programs, but then once those were over, they reverted to smoking. So the second one is, well, I've had 3 sessions. This is someone who led a smoking cessation curriculum, or a smoking cessation program with patients and community members. And they haven't been that successful, even though trying to get recruitment, trying to get people to come to her group. It's just the last session, I started off with 6 and then end up with 3. And so this one says, I received feedback from a person who participated in one of her sessions, and they thought it was really great. This is actually referring to the CHW in the second quote. They thought it was very inspiring, very encouraging, but they just, again, they still had all of these surrounding influences and factors that just wouldn't allow them to completely detach from that behavior. And in this case, that behavior is, of course, smoking. So there is a need here to consider the unique CHW care model and the interventions that are relevant to the patient population, all of the surrounding concerns that are particularly evident with these vulnerable populations that CHWs see. And is there any way to leverage their unique care model in addressing these concerns and increasing cessation efforts? So regarding training needs that the CHWs expressed, they really wanted specific details on how to address a lack of the readiness to quit. I want you to give me some talking points. Is okay, the client said no, they're not ready to quit. Okay, and they already shared with me that they already know the dangers of smoking. They're just not ready to stop smoking. That's where I want you to give me some talking points. Also discussing cessation in the context of specific health conditions. I alluded to before that many CHWs do specifically work with a chronic condition, and that will be the sort of presenting complaint or the chief complaint, like asthma or COPD. And so this participant, the CHW, says, I think another way we can be able to use them is based off why patients are coming in. Like if doing cardiology now, they come in for their heart and they're smoking, it's even more of a danger, to put that type of health risk on your heart when you're already on medications or you have a stent or something. So that's another good thing. We can kind of correlate the reason or a little bit of their health issues to why they should possibly stop. And then they requested specifically visuals and testimonial videos that can also portray health effects of smoking. And you can read that there. So we have wrapped up the analysis of that first focus group, and we are currently continuing. We've done a second round of interviews with stakeholders. These are CHW managers, and as well as 2 subsequent focus groups with more CHWs, because we've integrated some of that feedback and started to develop our curriculum. And we presented some of those curriculum content and data and presented to the stakeholders and the CHWs. Our next steps are really to finish the qualitative analyses of the stakeholder interviews in round 2 of those focus groups. We are really aiming to incorporate CHW feedback to develop the cessation training for CHWs modified from the 5 A's approach and specific to the CHW model of care, using a lot of the information from those groups and from the stakeholders. We are then going to assess the training's acceptability, their appropriateness, and their feasibility. We'll do these with all quantitative measures, and then we'll determine the preliminary efficacy on CHW tobacco knowledge and skills of the adapted training. So early in the spring of next year, we plan to administer the curriculum with a group of CHWs and hopefully get more feedback. And well, you can withhold your questions, of course, our question round, but thank you for your time.
Thank you so much, Dr. Veluz-Wilkins, for sharing all that. I love how different all of these presentations are. Okay, Dr. Brett, do you want to go ahead and share your screen and talk a little bit about your work? And again, if you have any questions for our presenters, feel free to use that chat box to ask them.
Yes, let me share my screen. All right. Can everyone see?
Yes.
Great. Well, thank you so much for having me today. My name is Dr. Emma Brett, and I also, like Dr. Vena, work in the Clinical Addictions Research Lab under the supervision of Dr. Andrea King. And I'm excited to share some results from one of our recent studies on effects of a brief smoking intervention in non-treatment seeking Black smokers. So why smoking? I doubt I need to tell many of us on the call here, but like you've heard a few times today, tobacco use is the leading preventable cause of death in the United States. And smoking is not only associated with lung cancer, but other cancers as well. So kidney, stomach, pancreatic, not even to speak of the other related conditions associated with smoking. So earlier you heard in Dr. Vena's presentation, a clinical trial for smoking treatment. And we also want to think about, there are some smokers who might not be ready to engage in smoking cessation treatment. And so you can see in this really simple graphic that there's a portion of smokers who have no real desire to quit right now. And then there's 40% who do want to quit, but they might not feel ready to be making steps towards that quit or to quit in the near future, whereas there is a portion, so about 30%, who are seriously considering quitting within the next 6 months. And so we want to think about not only how can we develop more effective treatments, but how could we maybe reach smokers who might have some ambivalence about their smoking, so maybe some hesitant about making changes towards a quit attempt? And so you might recognize this infographic. This should look familiar based on the last talk. And so we know that right now, rates of smoking, it's about 14% among adults in the United States, but this is not equal across all groups. So some examples are lower education, below the poverty level, Midwest, individuals with mental health conditions tend to be smoking at higher rates. One such example of this relevant to today's study that I'm going to talk about are underserved Black communities, where this prevalence is closer to 40%. And so that's really striking when we compare that to that 14%. And that's closer to what we were seeing in the United States in the 60s, right? So this is a really striking statistic, I think. Some reasons for this. And so we know that Black smokers tend to report more difficulty with quit attempts, even though there's just as much desire to quit and make these quit attempts, more severe withdrawal symptoms. And so makes sense why there would be more difficulty quitting if there's strong withdrawal symptoms, increased rates of tobacco-related morbidity and mortality, so related conditions like hypertension, diabetes. And we know that there's less use of nicotine replacement therapy or NRT. This is a key point, we think, because we know that these products are safe and that they can at least double the chances that someone will be successful in that quit attempt. And so we really think that some of these barriers would be important to address if we're thinking specifically of this population. So that's exactly what this study set out to do. And so how can we address some of these very specific barriers to try to increase motivation to change smoking? And so there were a few elements we wanted to incorporate into an intervention. So we wanted to have personalized feedback specific to that each individual person. And so this would be things like, what is your dependence on nicotine? What is your exhaled carbon monoxide level? So Dr. Vena mentioned that poisonous gas. We have a really cool machine that can show the level there. And so we wanted to be able to provide some personalized information. Similarly, we wanted information that was really relevant and specific to the community we were working with, right? And so we wanted to talk about things like how tobacco companies will really heavily advertise in these communities, especially with menthol advertisements. You can see some examples here, as well as other relevant information like the disproportionate impacts of related disease, the increased secondhand smoke exposure. So we thought having this really community-specific information would be relevant also. We also wanted to have motivational elements like highlighting benefits to quitting. And then we really also wanted to focus on the nicotine replacement therapy aspect. And so we hear all the time that there are a lot of misperceptions around the use of these products that people simply just don't know are untrue. So things like, don't these products cause cancer? Don't they actually continue my addiction? And so we thought it'd be really important to directly address those myths and provide education on the safe use of these products. And so in our intervention, we actually not only provided that information, but also gave people a 1-week sample of either patches or lozenges that they can use. And they had the opportunity to try it right in session. So this study was conducted pre-COVID. So this was a couple of years ago, it wrapped up, and we recruited, again, these were not necessarily people who were trying to quit smoking. These were non-treatment seekers, and we recruited through COMPASS, or the Chicago Multi-Ethnic Prevention and Surveillance Study. And we had 204 participants who were randomized to either treatment as usual or enhanced care. The treatment as usual would be something similar that someone might get if they show up to their doctor's visit, say that they're smoking, and so they were given some resources with a brief explanation. The enhanced condition, we had those elements that I talked about in the previous slide. So where we were talking about NRT and actually providing it, I'm talking about those specific statistics relevant to the Black community, and really trying to have this 30-minute targeted session with a psychologist. So our participants on average were about 54 years of age. Most were not currently employed and had a household income lower than $20,000. Most were smoking around 9 cigarettes per day, a high portion of menthol smoking, which is what we would expect in a Black smoking population. And most had been smoking for over 30 years. So these are people who had been smoking for quite a long time. We also saw a high level of experience of trauma in this population. And so we saw that 50% were reporting ever being attacked or mugged, and over 40% had witnessed shots fired or been involved in a shooting. So these were participants who had a high level of environmental stress in their lives. So our primary outcomes, we wanted to see if we could influence motivation to change smoking. So instead of focusing on quit rates like a cessation trial, we really wanted to increase motivation, given that participants didn't know they were enrolling in a smoking study. In fact, they were told that they could be getting feedback on any number of different health behaviors. And we were also interested in beliefs about nicotine replacement, how much they use nicotine replacement, and number of cigarettes that were smoked per day. So a few results. So for motivation to change smoking, higher levels on this ladder score would be more motivation. So you can see at baseline, both groups were right at this midpoint 5 level. And then at follow-up time points 1 and 6 months later, you can see that red line, that was the enhanced treatment group, was reporting significantly more motivation to change their smoking. For cigarettes smoked per day, again, it was close to 9 cigarettes at baseline. And then we see for the red group, again, is that enhanced treatment group, we can see that they more significantly reduced their cigarettes. So you can see closer to 4 cigarettes per day at follow-up time points. Changes in beliefs about NRT. And so higher agreement would mean that you think that the statement is true. So this is that one example I briefly mentioned, nicotine replacement products can cause cancer. At baseline, you see some endorsement of agreeing with that belief. And then in the enhanced group, after the intervention, there was less agreement with that belief, which is great. And then of course, we wanted to see, does changing those beliefs or misperceptions actually impact nicotine replacement use? And so we saw that for this enhanced treatment group, there was substantially more use of NRT at the follow-up time point. So we see a larger portion of the sample who was using nicotine replacement. So some conclusions. So we were excited to see that even just one 30-minute intervention could increase motivation to change these smoking behaviors, even among a sample that was not necessarily looking to change their smoking. So we thought this was great to show that you can intervene on some of these behaviors even before someone might be coming to us saying, yes, I'm ready to quit. We think that addressing barriers that are really specific to the community we're working with helped make this an effective intervention. So really considering what those barriers to quitting are and trying to address them directly in the intervention. And in the future, we'd hope to address some of the, consider those environmental stressors a bit more, potentially have booster sessions to try to maintain and improve upon those gains, as well as use technology, especially in the COVID age where technology can be really, really important for getting treatments out to people safely. And I want to thank everyone at the Clinical Addictions Research Lab, especially Dr. King, and happy to answer questions during the Q&A. Thank you.
Thank you so much for sharing all that information, Dr. Brett. So we do have some questions here that came to me in the chat box. So the first was, so Dr. King is on this call and she asked, she'll be interested in knowing what the next steps are in this line of work. So I wanted to ask each of you, specific to your research projects, knowing what you know, what are the next steps then? And we can start, we'll just go in the order that we spoke in. So we'll start with Dr. Vena.
Yeah, so we're really interested in diving into this data more, looking at it more closely, seeing if there were any factors that might have predicted treatment success mostly within that combination treatment approach. And then of course, continuing to pursue this line of research, doing these clinical trials are very fulfilling. And if there's anything that we can do to ensure that we focus mostly on those 12 weeks of treatment here. But if we can look beyond that and help people remain smoke-free, so not only do we help them quit, but do they stay quit? That's really our next goal, is to help make sure that these effects are long-term.
Great. And Dr. Veluz-Wilkins?
Yes, so we are hoping to wrap up the qualitative analysis from those stakeholders, again, those who manage community health worker programs, but we've also been in contact with, for example, the Malcolm X College Community Health Worker program there. What we want to do is, as we continue to develop the curriculum and then evaluate the efficacy of actually increasing knowledge and skills with a cohort of community health workers in a clinical trial, we want to work with program directors to see how we can sustainably integrate that curriculum and make it readily available to disseminate that. And make it, in Illinois, I believe in 2016, the community health worker certification process became more formalized. And so they've been developing guidelines. And so we'd like to work with them to see what they need in order to be able to integrate tobacco cessation and what they do from a training standpoint. So those are our next steps.
Great. And then Dr. Brett.
I would love to see what we can do to build on those motivation gains we saw and really keep the ball rolling with those gains. And so I'm particularly interested in how we can leverage technology to do that. And so booster sessions by video, by phone, by text message, things we can do to keep that motivation going long term that might move people who are in that middle ground of like, yeah, I want to quit, but I'm not so sure, to really give that extra boost of motivation where someone might feel ready to set a quit date or ready to start using nicotine replacement. And so I'd be really excited to test some booster sessions using technology to see how that could impact the effects.
Great. So we have a question in the chat here for Dr. Vena. It says, did any of your participants that use Chantix complain of being very irritable and almost combative? I asked this because this happened to someone that she knew while using Chantix.
Not so much. I mean, not specifically in our study. I will say that quitting smoking can be a stressful process. It's very challenging. And so there might be some effects on day-to-day effects on how you're feeling, on some mood changes. And that was very normal. We did see some people that were, they basically were using smoking as a way to deal with life stress. And when you take that away, it takes time to develop new coping strategies. And so that was something we did see a lot in C-STOP. And really, that's where the behavioral support came in to help them identify new coping strategies, how to cope with some of these side effects of Chantix. It wasn't just Chantix too. We also saw some side effects with the nicotine patch. Sometimes quitting smoking can affect your sleep also, and that can definitely increase irritability, making you just feel more uncomfortable. So, not specifically, but it is a stressful process, and everyone kind of experiences that process differently.
So I had a question about, I wanted to ask, what's the most rewarding part of your work, and also what's the most challenging part? I imagine that a lot of you have similar rewarding experiences, but the most rewarding and the most challenging part of your work. And again, we'll start, actually, let's go in reverse. Let's start with Dr. Brett and go back to Dr. Vena since she just spoke.
Yeah, sure. I think the most rewarding part is when you do have success in helping someone quit smoking. I mean, that's the obvious answer, but I have a clinical psychology background. And I remember when I first started the clinical part of my training, one of my early supervisors was like, all of this clinical intervention's great, learning about all of these mental health conditions so important, but the single most important thing you can do for a patient who's smoking is help them quit. And that just like really stuck with me. And so I think that when that can happen, that's quite rewarding. Challenging, I think it is so hard. I mean, smoking is a really tough addiction to get through. And I think when you hear the challenges people are facing, whether it's community violence, whether it's self-stigma or stigma from others about smoking. I think that's the most challenging part to address.
Dr. Veluz-Wilkins?
Yeah, similarly, my background is also clinical psychology. So I think the most rewarding are individual successes that when I've worked with clients, participants, and with groups, the interactions and seeing successes. I loved the thank you note that you got, but knowing that the struggle of being a smoker for 42 years, the work that you can do with someone, or you can do in a group setting where you can help people kind of steer and help steer them to do things like increase their motivations and just better understand what they can do from a coping standpoint to quit and then stay quit over time is really, really rewarding. I also really love the work we do with community health workers. They are amazing. And part of the reason that both Dr. Tan and I moved in this direction is because they really have the ability to serve so many more people. And so knowing and they have so many skills and strengths that it's really exciting to me to be able to say that we can leverage that. From a challenge standpoint, I think a lot of it is dissemination of what we know as scientists and as researchers and getting it out there so that we can get the information and the skills into the hands of the people who need help. I think there's always this gap. You know, we can sit and do these clinical trials, and we've done clinical trials and develop all these things. And I would love there to be some kind of streamlined way to just push it out there so more people can take advantage of it. So we're working on it.
Great, thank you. And Dr. Vena.
So I actually have a very different background from the other two speakers. My training was more in pharmaceutical sciences. So I worked with animals before coming to work with Dr. Andrea King. And so this was all a whole new space for me. I actually got training from Andrea on delivering smoking cessation therapy and treatment, the behavioral component of the treatment. So this was a whole new territory for me, but I loved it. I found it extremely fulfilling. Those success stories like really kept me going throughout my week. So I found it just really rewarding connecting one-on-one with these participants and knowing that I was helping them accomplish a really huge but tangible goal for them. And I will echo that some of the challenges that were encountered are similar to what Dr. Brett and Dr. Veluz-Wilkins mentioned, are about, reducing the stigma associated with tobacco use disorders, alcohol use disorders, all kinds of various addictions. Because unfortunately, I think sometimes stigma does interfere with people getting treatment. And also, like you were saying, Veluz-Wilkins, about getting our science out there. And that's been something that I've always found a challenge. And I think we all kind of experienced it too with, the whole pandemic. It's just something I think that researchers can do better in disseminating this information and making sure that people have access to correct and accurate information for making decisions.
A really great point. We see that a lot in general in public health these days. So in the interest of time, I don't see any other questions here, and I don't see any other questions on Facebook. So huge thank you to our panelists, Dr. Vena, Dr. Veluz-Wilkins, Dr. Brett. Thank you so much for taking time out of your day today and sharing this just super important work that you're doing. We're so appreciative of all the knowledge and all that you're doing. So thank you again for what you do and for being here today and speaking with us. We really appreciate it.
Thank you. Thanks for having us.
Yeah, thanks for having
us.
Have a great rest of your day.